GECHO meeting, which is hosted by the Gastro Foundation in association with Project ECHO and the University of New Mexico. These sessions are held every Wednesday. There are 41 registrations from 11 different countries for this particular meeting, and this is the final GECHO meeting for the year. This afternoon, the speakers are Rashid Nashadengo, followed by Edward Jonas. Rashid is a HPV surgeon in Namibia who did his HPV training with us in Cape Town. And like I said, he's going to speak about the management of HCC in Namibia. Thanks, Rashid.
Thank you, Mark. I'll just share my talk. Is it clear on that side?
Yes, it's coming up.
Oh. Okay, thank you so much for giving us the opportunity once again to share our experience with the in the management of hepatocellular carcinoma in Namibia. So just a way of overview of my presentation, we'll introduce a bit about the situation in Namibia, and then review the Barcelona staging, especially also the latest update. And especially, I'm going to review some of the cases that we managed so far here in the country, and then we'll conclude. Just by way of introduction, we all know that hepatocellular carcinoma is currently ranked number 6 as a common malignancy globally, and it's the second most common cause of cancer-related death. The incidence has been growing, and the WHO has predicted that more than 1 million of patients will die from the disease annually by the year 2030. It carries a poor prognosis, and the prognosis, as we know, it's related to the disease stage. And you know that some of the causes include hepatitis B, especially in the African context. In the Western world, we have the metabolic as well as non-alcoholic disease of the liver. Furthermore, we know that most of the patients with HCC, they reside in the resource-limited countries, especially in the Sub-Sahara and Eastern Asia, which account for about 80% of newly diagnosed HCCs. And we all know that, and we all experience patients presenting with advanced disease or terminal illnesses to our clinics. So this is Namibia in the southern western part of the African continent. This is our capital city. I'm based, I work both in the private and the public setting at the Windhoek Central Hospital. Most of the cases we do for liver, as I've explained later, are done in the private because we don't really have a setup for liver surgery in the public sector as at the moment. So the data on hepatocellular carcinoma in Namibia is very, very scarce, especially the fact that we don't really have good registry for these patients. But what I gather from the last Namibia National Cancer Registry more than 6-7 years ago is that the liver cancer, hepatocellular cancer, it's common more in males compared to females, with a proportion of about 2.6% of all the cancers in the male population, and about 4 in 100,000. This is actually based on pathological diagnoses. It excludes a large number of patients who had imaging done, but did not have biopsies as such. So we all know that there are lots of treatment guidelines that are based either regionally or country specific. And what we're all familiar with is the Barcelona liver clinic algorithm. This is their latest upgrade following the recent meeting. And they've started to actually incorporate other things that were not really incorporated before. I don't want to go into detail, but suffice to say that now they've started to include things like alpha-fetoprotein in the management algorithm. The first treatment options still remain the same. The curative intended approaches like ablation, resection, and transplant, followed by the intermediate group stage of arterial chemoembolization option. And we now starting to recognize that TACE is also incorporated now as a way to downstage patients for possible transplantation. So this is the latest guideline since October this year. However, we still notice that up until recently, we know that the Barcelona algorithm does not really include all the other known treatment options for HCC. For example, SET is not really incorporated yet, but slowly but surely, I think people are starting to identify different studies that have incorporated SET in the treatment or downstaging of HCC. External beam radiation has been discussed, but it's not really as available. We still have more data that we should get to probably incorporate that. And we've also noticed that the intermediate group, the B, Barcelona, it contains a heterogeneous group of patients with HCC, either depending on the number of tumors as well as the clinical Abcr scores. And furthermore, we know that the Barcelona does not really also consider patients with child C cirrhosis for transplantation. That has been pointed out in some reviews. And also we know that although they recommend liver resection for single nodules in patients with absent portal hypertension, there are new studies also showing that patients who have maybe a bit of advanced portal hypertension, sometimes they can do well if they're managing a good environment with support from hepatologists and all the other patient specialists. And also we know that also such studies also have demonstrated there's increased good survival when you operate patients with advanced HCC who don't necessarily fall into the Barcelona criteria for resection. So furthermore, we know that when it comes to the treatment of HCC, the treatment options are largely divided into curative intended options as well as palliative intended options. For example, we know that hepatic resection, liver transplantation, and local abstention do fall under curative intended options, although we know that there's a possibility of recurrence. Okay. Embolization is one of those things we don't really know whether it does well or not. And of course, medical treatment and best supportive care falls under the realm of palliative care for patients who are actually fit for that. So I'll just want to get just to review what are the options available in our country at the moment. When we look at the treatment options as offered by the Barcelona, ablation as such, it's not available. We haven't obviously started doing ablation, although we can, it's not actually very difficult, I think, to get equipment in because we already have microwave ablation for, or radiofrequency ablation for Barrett's, for example. I don't think it will be difficult to obtain it, but at the moment we don't have it available. We cannot offer it to our patients. We do have resection. We will review some of the cases that we have done since we started in 2019 when we came back from training. Transplantation is not available in Namibia. However, there's living-related transplantation that we can refer the patients to, for example, to Johannesburg at the Gordon Center. And for somebody to have transplantation, other forms of or cadaveric transplantation, they have to have permanent residence to go to South Africa for that. TACE, we have recently started TACE. We'll also review some of the cases that we did since 2020. And of course, systemic treatment is available as well as base support. So far, when we've started HPB units in Windhoek from January 2019, we had a total of 22 liver resections. By and large, most of them are colorectal liver cancer metastases, liver resections, and we only managed to do 4 patients for hepatocellular carcinoma. I'll just go through the 3 cases that we've done. Some of these cases, we've actually presented them before on the GECHO platform. The first case is a 56-year-old male who's a Navy officer with sober habits. He is known to a physician with the chronic hepatitis B infection for over 15 years, virally suppressed on entecavir, and he's also HIV negative. He presented with the right upper quadrant pain. There was no obstructive jaundice or weight loss associated with this presentation. His Child-Pugh score was actually 5, and he had a CT scan. This is just the still imaging from his CT scan. So we can see in the arterial phase with enhancement of the tumor predominantly on the right side of the liver, which demonstrates washout on the venous, on the portovenous phase. And we thought the liver did not really look cirrhotic. His Child-Pugh score was actually good. So we decided to offer him surgery. We did a right hepatectomy for him, formal hepatectomy. Histology came back confirming hepatocellular carcinoma, and the margins were very clear. And up to now, patient is actually doing well. He only had a mild bile leak that we may actually manage with ERCP and the stent, yeah, so that actually sorted out the bile leak. The second case, again, I think it was also presented at the ECHO meeting, is a school teacher, was 51 years old male, with a co-infection of HIV and hepatitis B. Both viruses were well suppressed, but there was a concern that his hepatitis B antigen remained persistently positive, despite 2 one-year course of Pegasus. And the liver nodule was first detected in 2018, and it was not referred to any surgeon during that time. And in fact, when he was referred to us, he already had a biopsy done by the physician, which confirmed a liver cancer. So we did a resection for him in 2020. And this is just his the MRI scan. You can see the lesion there in the left lateral segment. They were, of course, we were concerned about these satellite lesions around the main lesion. And these are the pathological specimen of the left lateral segment. You can see the other satellite lesions. Obviously, it was a concern, but we're happy that all the lesions were completely excised. And on the background, although the imaging was not really in keeping with cirrhosis, there was histological confirmation of cirrhosis and as well as hepatitis B. So those are the 3 cases I just wanted to review. Now going to embolization, we know that the current guidelines is based by the Barcelona criteria is mostly for intermediate group. And we look at the tumor factors, for example, the size and whether the nodules are multiple. We also need to look at the function of the liver. So patients with preserved liver function tend to do well, okay? And also the performance score of the patient. And the good thing about TASE is that you can actually repeat it. And it does offer patients on average about 20 months of improved survival, as most studies have shown. So just furthermore, so TASE can be offered as a primary treatment for unresectable HCC. And lately, more studies are showing that it can also be used to downstage for liver transection. Most of the articles are showing that. Rarely it has been used for downstaging for resection. And as I mentioned that it's for Barcelona intermediate stage B. And the rationale behind TASE is that the hepatocellular carcinoma gets a blood supply from the hepatic artery. And we use this advantage or this fact that so that we can actually infuse cytotoxic agent or chemotherapeutic agent followed by embolization to the tumor feeding vessel. So we are actually using a combination of cytotoxic effect of the chemotherapy, as well as the ischemic effect to the tumor. And we need to distinguish it from bland transarterial embolization, where there's no chemotherapeutic agent applied to it, and as well as chemotherapy with no embolization. So it's actually a combination of chemotherapy and embolization. And we have different types. We have conventional TACE and also the drug-eluting bead TACE. And lately, in Americas, there's been some articles with radio embolization. So I'm not going to talk about the different TACEs, but I just want to share our experience. So far, we haven't yet published any of this. We're just going to cases so that we can share our experience formally. So since 2019, we started, or actually we actually started in 2020. And there hasn't been any interventional radiologists are keen to do these procedures with us. So we have actually approached the vascular surgeon, who was a colleague in the state, Dr. Gesson, who trained at Stellenbosch. And he's more doing all these endovascular procedures. So we know he has experience in embolization as well. And so far we've done 7 patients, of which 5 are hepatitis B associated hepatocellular carcinomas, 2 are non-hepatitis B HCCs. With the first 3 cases, we used doxorubicin. With advice from Professor Benningfeld in Cape Town on the dosages of the doxorubicin, with also our oncologist this side. And then we inject doxorubicin first, and then we followed up with the coils for embolization. Okay, so we found that this actually limits further procedures, because the coils obviously just close off the artery or the feeding artery completely. And then the last 4 cases, we used the microbeads. So we started using the drug-eluting bead stays, and the sizes of these beads were 300 microns. Okay, so what we do, we mix it about 2 hours before the procedure. So we need to liaise with the pharmacist so that we can mix the doxorubicin, about 50 milligrams, with the beads, and let it soak for some time. And this is a syringe showing the solution of the microbeads with the doxorubicin. Okay, and the advantage of using this, obviously, compared to coils, is that you can actually then repeat the procedure later, because you don't really close off the artery completely. And most of the tumors that we've done are actually bigger tumors, more than 10 centimeters in diameter. Okay, we'll show some of the images. And one of the patients is actually had a tumor that was growing into the IVC. It's a young patient, good performance score. We thought we can offer him. He's still waiting for the 90 days to pass so that we can re-image and see whether the treatment has worked or not. And one of the patients actually have a repeat TACE. Okay. And what we do is that we repeat the CT scan after 90 days, so that we can actually assess whether there's been any response. And we really request our radiologists to use the modified RECIST criteria to assess for the response to the treatment. And for those patients who we think that they can benefit from more procedures, we use the Abcr score. We'll review shortly. And this is actually the setup. This is actually a cath lab at one of the private hospitals. For the private patients, it's easier, but for the state patient, we have to get authorization from the hospital superintendent's office so that we can actually do these procedures for these patients. Okay, and it's a cath lab, like I said. It is shared between the vascular surgeon, the neurosurgeon, as well as a cardiologist. And this is also the place where we do our endoscopic retrograde cholangiopancreatographies. at one of the hospitals, local private hospitals. And then don't want to dwell too much on this. Suffice to say is that when the radiologists assess, they need to tell us whether there's been complete response or at least partial response. And there's a standard definition depending on the targeted tumors or non-targeted lesions and the vascular appearance of the tumor, whether the patient, the tumor is actually undergone necrosis and there's no contrast uptake and all these things. So this is what we encourage our radiologists to actually use to standardize the assessment post-TACE. And this is just showing the algorithm that we usually start looking at the patient's or disease characteristics. And we usually take patients who are very fit with preserved liver functions, okay? And we offer them TACE. And then the question is when to image. By and large, we actually image them after 90 days, okay? Some people will argue that maybe it's actually too long, and some studies have actually shown that maybe it's better to image them from 6 to 8 weeks. So we do usually a CT scan, and then we decide whether to TACE, okay? And whether to TACE depends on different things that we actually look at. Okay, and if there's been any disease control, then we can either decide to follow up the patient or maybe to offer the patient more TACE. If there's been obviously progression, and we had 1 or 2 patients who have actually progressed after the TACE, these are the patients that then are referred to oncology for either sorafenib. In the state, unfortunately, we don't have sorafenib. They usually end up getting either doxorubicin or something equivalent. And sadly, that sometimes you don't really get the feedback for what happened to these patients. This just shortly the Abcr score, sorry for that. And it's basically to consider the A stands for the alpha fetoprotein. We need to see whether it's more than 200 at baseline. You need to look at the B stage Barcelona, and also the Child-Pugh score, and whether the patient has responded. So if the patient has responded and the Child-Pugh score is actually either A or early B, then we can still then offer the patient without really costing much morbidity to the patient with a repeat TACE. And this scoring has sort of been not really, it has been sort of been validated, but not really major studies. But this is more the guidelines that we use when to decide to offer patient a second TACE or not. And this is one of the patients. That patient, if remember, we did a lateral left sectionectomy. At 8 months, we noted that the alpha fetoprotein was going up. Initially, it has actually come down post the resection, and at 8 months, it went up to 142. And then we did the imaging, and we found that there were lots of multiple hyperdense lesions that we could see on his CT scan. And most of them were mostly localized to the right side. And because we couldn't really offer him microwave ablation, some of the lesions were a bit too deep. So we said, okay, we can offer him microwave ablation, and he's still young, he's a teacher, so let's maybe offer him a TACE. So we did offer him a TACE. We went through the brachial, the catheters coming from the brachial artery axis. And obviously we just basically, it was more like we TACE with the drug-eluting beads, the whole entire right side. He actually improved the alpha fetoprotein prior to that was about 1,000, and then it came down to 38. Okay, when he came back, we repeat the imaging. We thought that we couldn't really see some of the lesions, and we offered him for a second TACE. So this is one patient who had a second TACE. Yeah. And unfortunately, after the second TACE, he got septic, and he stayed in the hospital for about maybe a month. and then he was stepped down to a facility. He didn't really recover from the sepsis, and then he demised about 2-3 weeks ago. So the question is whether should we have him maybe just followed him up, or was a taste really necessary? At that time, we thought, okay, he's still young, so maybe we can still offer him taste because he's actually improved very well. But yeah, so those some of the lessons that we learn along the way. And then the first case, this is actually a young patient that we've discussed with Professor Benningfield and also Professor Jonas in Cape Town. 16-year-old female who is a pupil in one of the local, actually nearby towns called Rehoboth, with a previous history. There's no actually previous history of hepatitis B. She presented initially to a GP with right upper quadrant pain and a mass that is palpable. And she did not really have any signs of chronic liver disease or portal hypertension. The AFP was not really elevated. And upon the discussion with the expert radiologist, we thought this could be a fibrolaminar HCC. So this is one of the snapshots of the patient. You can see that the only part of the lung or of the liver that is spared is the left lateral or segment 2 and 3. And we asked for the calculation of the possible future remnant because we thought that maybe she would need an extended right, but we're just concerned because it was just looking too extensive. And also there's a possibility that maybe the right portal vein was infiltrated. So we decided that we should rather do a TACE and to assess whether we can downstage it and reassess for maybe surgery in Cape Town. So she was only TACed in October this year. She'll come back sometime early January so that we can rescan to see whether the treatment has worked or not. So this is just her imaging. Sorry if it doesn't portray so well. This is the celiac axis. We noted that there was a bit of a narrowing there, which we can't really explain why. The tumor is not really invading the celiac axis there, although it was in close proximity with the common hepatic artery. And we could see that there was a lot of vessels supplying the tumor. And we just basically do the DEB TACE. And she had a bit of abdominal pain. So, but she's doing well now. So we just have to wait until we repeat the scan to see whether there's any response. So in terms of the complications, most patients do experience what we call the post-TACE syndrome, which is associated with abdominal pain, with nausea and vomiting and a bit of a fever. So that's why we keep the patient for about 2 to 3 days in the hospital post the procedure. So 2 patients were discharged after 3 days, and then they have to be readmitted because they were vomiting at home. 1 patient developed upper GIT bleeding. We don't really know. We thought that maybe there was a retrograde flow into the left gastric artery. We put it in the scope and we could see there was just hemorrhagic gastritis, almost the entire abdomen. We took some biopsies, so that's the biopsy, and we thought that maybe on the biopsy we'll see some microbeads, but there were no microbeads reported. It was just basically severe hemorrhagic gastritis. Patient settled well on IV PPI. Unfortunately, the same patient developed also a liver abscess, which has to be percutaneously drained, and it did well. We didn't have so far any patient who developed liver decompensation or post-TACE liver failure, and we didn't have any patient dying, although we can say maybe the second patient, although there was sepsis and acute kidney injury, maybe it was somehow related to the second TACE. So in conclusion, we have actually noticed that we need to develop our local HCC, and restriction is available, but however, for the major ones like extended, we haven't really much experience in that. We usually refer them to South Africa for that, to the team there. And so far, we haven't had any mortality related. So it's very nice to choose our patients carefully, especially in noting that we do not have a pathologist available in Namibia at the moment, although we do have people with interest and one medical gastroenterologist for the whole country. We can offer taste to patients either as a primary treatment. We still have to see whether the downstaging for the 16-year-old will work. And we do have an enthusiast or a colleague from vascular surgery who can help us with the procedures. And we also realize that we also need to build an audit so that we can share our experience so far. And we do welcome any future collaborative research and also registry. With that, I thank you for your attention. And if there's any questions, then we can discuss later, or any suggestions. Thank you very much.
Thanks very much, Rashid. That was very interesting. I think we'll do the questions now. So if anyone has any questions, if they could please put them on the chat. One question that I had, and I'm not sure if I should direct this to you, Rashid, or to maybe Wendy Spearman. Just as a matter of interest, I see that the one patient that you had who had hepatitis B was treated with entecavir, which is not a drug that we commonly use. And I was just wondering, you know, when you would choose to use that as opposed to one of the more common agents like Namibia or tenofovir. And then also the patient that you had that progressed after surgery, that patient also had HIV, if I'm not mistaken, or was that HIV and hepatitis B?
Thank you for the question, Mark. Yeah, so I'll only answer the second one. Yeah, so the patient who was a teacher, actually, he's the one who actually progressed, who post the resection. And he's also the one that had a second case who ended up actually demising after a month or so after their second case. Yeah, so he was actually co-infected, and it's the same patient that we presented before who had hepatitis E antigen that was not really cleared all this time for, I can't remember how long it was on the treatment. Yeah, so whether, because there was now a discussion, was the positivity of the E antigen a contributory, or I don't know. It was also not so clear from that discussion when we had Professor Spearman and Sandarab on the meeting. Yeah.
It was, my question was just also, you know, I think HIV and hepatitis B are often, co-infections aren't that rare. And I was just wondering if there is, and maybe Professor Spearman could answer this, if there is evidence that those patients do worse after liver resection, and how they do generally.
Yeah, thanks. So, I mean, in terms of the first-line therapy for hepatitis B, we're basically looking at tenofovir, allotheriumide or tafnat, and entecavir. And in terms of entecavir, it doesn't really have any benefits over tenofovir in terms of viral suppression, but it does have a benefit in that it's relatively renal friendly. So often before TAF, if you had renal impairment, you would use entecavir. One of the problems is that if you've been previously exposed to lamivudine, then you get cross-resistance and you can't use entecavir. So really, lamivudine, we really would actually only use in the setting where we want to rapidly bring down the hepatitis B DNA level. So somebody coming in newly diagnosed with HCC, high viral loads, lamivudine will bring down your hepatitis B viral load very rapidly compared to tenofovir, which can take up to 48 weeks, or entecavir. And you're only going to run into resistance with lamivudine around about 6 months. So there's no problems. We now do have access to TAF, which has the benefits in terms of renal protection. And I think just in terms of the cost, I mean, we get tenofovir, and most of sub-Saharan Africa will get tenofovir at this of $32 a year, whereas entecavir, in rand terms, we pay about 5,000 per month. So in terms of costs, there's quite a big difference compared to tenofovir. And even for TAF, if you bring it in, you probably pay about 400 rands per month. So there's definitely a benefit in using TAF over entecavir. And then there's a small risk of resistance with entecavir, about 1.2% at sort of 2 years, 5 years. So I think we've kind of moved on to tenofovir or TAF now, but entecavir is good. Sorry, the other question, Mark, was?
About HIV and Hep B co-infection and outcomes after surgery, and just outcomes in general.
Yeah, so I mean, unfortunately, patients of HIV, hepatitis B co-infection are still presenting untreated, unrecognized, and presenting with multifocal HCC. They have a much more aggressive course. They tend to have a much shorter survival, and even if you get them onto antivirals, seem to do worse than if you have mono-infected. So I think one of the problems is that, we screen for HIV, we're not screening for hepatitis B surface antigen. So we need to, those patients who have co-infected should be in a very close surveillance for HCC. So we would do that sort of 6 monthly.
Okay. Thanks, Winnie. And then there's just one question I see on the chat by Anthony Okenit. It says, on the same patient, what about the choice of pegylated interferon?
Do you want me to go for that?
Yeah, I know nothing about that.
So, I mean, pegylated interferon, and unfortunately, it's really a very limited clinical profile that actually would be suitable for pegylated interferon. So you need to be young, you need to have a low viral load, usually less than 1 million. And you need to have evidence of active nectar inflammation, so an active hepatitis, because basically what your interferon is upregulating your immune system, which is really, it can't actually jumpstart it, it really just augments it. So unfortunately, most of our patients have, ALTs maybe 1.5 times upper limit of normal, have very high DNA levels. So our responses to pegylated interferon are not as good as you see elsewhere. There is an increased response if you're genotype A as opposed to genotype B, C, or D. So in Cape Town, where we have a predominance of genotype A, we have had some success, but it's a very small proportion. It's a year's therapy, it's very close monitoring. And you really do need to have a liver biopsy before embarking on pegylated interferon. So I think once you've had one course of pegylated interferon, I don't think repeating it is going to make much difference. I think the future of pegylated interferon is really going to be when we start looking at curative therapies, where you're actually targeting the virus with decreasing replication, targeting triple cDNA, and boosting your immune system. So I think there's still going to be an important place for pegylated interferon, but part is combination therapy, curative therapy.
Are there any other questions? Rashid, I was just wondering, Namibia, I'm not sure what the population is, but it's not huge. How easy is it to try and increase awareness throughout the country of hepatitis B and HCC, and how easy is it to improve screening for at-risk patients? Do you think it will be easier to do that in Namibia because of its smaller population than South Africa, or is it a big problem?
Thank you for the question, Mark. So I think from the last census, the population is about maybe 2.5 or 2.6 million. So it's not really a big population per se. And with such a small population with, it's just something that we really need to get much involved in terms of advocacy and all these things. We have radio platforms that we could use, and also television and all that. It's just that we haven't really, I think it's a good suggestion that those are the things that we need to get ourselves involved in, because we're really passionate about hepatitis B and also hepatocellular carcinoma. So it would be nice to start doing some of these things. Yeah. Okay.
If there's no more questions, we're going to move on to the next talk by Professor Jonas, who's the head of HPV surgery at Registry Hospital at the University of Cape Town. And there's been some requests about whether, based on the talks that we've given this throughout the year, whether we should consider setting up a an HCC registry, and Professor Jonas is going to talk on registry-based research pros and cons.
Right. You see, am I unmuted?
So we can see it and we can hear you, Ed.
Ah, okay, fine. Thanks, Mark. First of all, Rashid, thank you very much for a very nice presentation, and congratulations with what you've established, I think, in a very short time. To have TACE and resection now up and running was really certainly not a very easy task, but well done. Just one comment on ablation. We mustn't forget that there is still the option of ethanol ablation. It's not as good as the thermal ablations, but if there are patients that would need an ablation rather than anything else, and you don't have thermal ablation, that could still be an option. And I think there was also a comment, unfortunately, I don't have the comments in front of me now, about the work that you've done and how much it is needed. So just in the next few minutes, I'm going to talk about registry-based research, the pros and cons in general. Mark will be more specific about it in HCC, but as you know, whereas we've always practiced medicine based on clinical expertise and patient values, what patients want as well, it's no longer the oldest professor's opinion about things that is the right one. We work with evidence, and evidence-based medicine has really been the standard across all medical specialities. And I think many of you know this triangle, where you get the quality of the data improving from the bottom, starting with an expert opinion, only what people think, not based on anything, quite limited impact from case reports, but then we go into case control studies, cohort studies, and then randomized controlled trials. And then as you go up, systematic reviews, preferably of randomized controlled trials, and eventually combining meta-analyses with the systematic reviews. And that is really where the strongest or the best evidence is at the moment. And if you're going to sort of translate those into treatment guidelines or guidance, the recommendations will be very strong up there and pretty weak down here. Randomized controlled trials, they often sort of mentioned as the holy grail. I think this was a tongue-in-the-cheek publication published in the British Medical Journal 2003. So these three co-authors performed a systematic review of randomized controlled trials that were performed on parachutes to prevent death and major trauma related to the gravitational challenges. And they've actually worked the whole protocol up and with a very good objective. The design, as I said, was a systematic review of randomized controlled trials, but they didn't find any. And I think this is one of the examples that of things, not everything should be tested in a randomized controlled trial. Some things are very evident, doesn't need to be tested, and they have a go at the end there. I think about at people that sort of go over the top a bit with evidence-based medicine as well. So I want to talk more about cohort studies and case control studies, and that is really the area where registries or databases come in. There's a lot of advantages or possible advantages with registry-based studies. So they complement randomized controlled trials. Certainly randomized controlled trials, if well performed and well powered, still generate, I think, some of the strongest evidence. But it doesn't always present clinical realities. We know that in general, patients in randomized controlled trials receive extra attention, and the results improve just for that reason. So there's already a bias in that. It doesn't necessarily reflect clinical realities in day-to-day medicine that we practice. And I think that's where registries come in very strongly. They usually require less financial resources as randomized controlled trials that we know can be very expensive to perform. The data collection, depending on what you study, but certainly in some fields on very large patient cohorts, less or no selection bias is present. They most often carry valid statistical power. The publications coming from these registries, if they're big enough, and they also enable conducting studies focusing on rare events. So if you've got 100,000 cholecystectomies in a registry, there may be some complications that are very rare, and you're guaranteed to pick up a few of those in that, and you can actually report on very rare events as well. And it's very close to how patients are treated, and not infrequently, the results of these studies actually directly impact on how patients are managed. A registry is not a registry if it's not checked, and in countries where there is a registry culture, and in many countries it's mandatory, you've got absolutely no choice whether your patients go into a registry or not. It's going to be done for you, and the patients are going to be followed up for you. They do look at, and there's usually independent bodies doing that, looking at the coverage of the registry. In other words, did you get all patients that qualified for the registry registered in the registry? There's also the completeness. In other words, are all the fields filled in? And then at the end, the accuracy, where there will be random picking of patients that were entered in the registries, and those will be matched with patient folders to see if they concur. And in the good registries, the coverage would be in excess of 95%. Completeness, always a little bit of an issue, but more than 90% is expected, and accuracy in that range as well. We know that there's a lack of registries in South Africa, or in Africa, specifically Sub-Saharan Africa. Rashid has already mentioned the fact that there's very little data on the incidence of HCC in Namibia. We just don't know what the true incidences are. And much of the data that we have come from studies, and I think we've showed this one over and over during over the past year, about snapshot surveys that were done in countries that gave us an idea of how patients on the continent are treated for HCC. There are some obstacles, and we certainly are faced with those down here in Cape Town as well, that we still do not have a reliable hospital database that we really can rely on to get the right ICD codes off from. We still have patient documentation, paper patient documentation, and working through those folders with often illegible handwriting is really not easy. We unfortunately do not have access to the death registry in South Africa, so we have to sort of physically contact patients or their relatives to find out whether they're still alive or not, if a death is not documented in the hospital registry. Follow-up is really a challenge for us, and I think that's for most sub-Saharan African countries. Patients come from far, they want to get back to their families as soon as possible, and we do have problems sort of getting up to high proportions or percentages of patients being followed up. Also non-compliance, not all clinicians think that registries are important. And it makes it even more difficult if there are no dedicated resources. Again, in the countries where they sort of basically run their health systems with the help of registries, there are dedicated resources to run those. If you do studies from registries, there are guidelines when you report case series or cohort studies. One of these, and I think one of the most commonly ones used are the strobe guidelines. I'm not going to go through those, obviously, but just one thing that makes it quite difficult, that makes it quite difficult for us, is that you actually have to start with a number of patients presenting with a disease before you're going down to reporting on a treatment. So in the case of HCC, it would be nice to know how many patients presented in your catchment area, or if you do a national study in the country, to see what proportion of patients are treated. And I've looked recently at some of the Scandinavian data. You can almost from day to day see there what the impact of screening on HCC was, how the proportions of patients that qualified for curative intended treatment increased, and also the outcomes. So really a very valuable resource that I think we should consider also to start introducing outside only of the only national registries that we at the moment run in sub-Saharan African countries. Thank you very much. So Mark, I think you'll be next, just focusing
Thanks,
on registries and HCC.
Okay, I'm just going to share. Can you stop sharing it? Okay. Okay, thanks. Can you see that?
Yeah, we see it well.
Thanks. So what's prompted this talk is that, like I said at the beginning, there's been some discussion with various individuals who've been involved in some of the meetings through the year about how we could better record cases. So I just want to make the point, that global surgery and basically improved access to surgery is sort of a fashionable thing at the moment. And obviously, as surgeons, I think we need to take advantage of that. And it's become clear that that essential surgical care needs to be included as a component of universal health coverage. And the major stumbling block in sub-Saharan Africa to improving surgical services is just the lack of robust data, and that makes it very difficult to improve things, and also to motivate for more resources. And this is the data from the South African Cancer Registry, and it's very similar to what Rashid presented from Namibia. And the National Cancer Registry in South Africa is also based purely on histological diagnoses. And if you look at cancers of the liver and bile duct, so it's not even just liver cancer, and this is 2017 data, there were only 300 reported or cases that were captured in the registry, made up 0.75% of cancers, and the incidence was only about 1 per 100,000, which we know is very low, and we know that we live in a high incidence area for HCC. So these registries already put us on the back foot when we're trying to motivate for more resources, and HCC, I think, is just not seen as a priority, and we are partly to blame because I think it just hasn't been something that's been diagnosed, and it's been diagnosed at a very advanced stage when there's not much that can be done. So my Q has published a lot of things on HCC in sub-Saharan Africa, and he made the points that it's often not diagnosed, it's often not recorded in registries, and he estimates the incidence in this publication in sub-Saharan Africa at about 41 per 100,000 cases. So that would suggest that we're missing about, we're only picking up about 1 in 40 cases in our registry. We also know that the majority of cases are diagnosed at an advanced stage, that treatment modalities have not been widely available. And we also know that there's virtually no published reports from sub-Saharan Africa of patients being treated with curative intended treatments for hepatocellular carcinoma. So I presented this data earlier in the year, and this is from the HCC registry that we started about 5 years ago at Abcr Score, and we followed patients up for 5 years, and in that time we entered 152 patients into the registry, and only 21 patients were treated with curative intent. And if you look at the data that we collected, it is quite simple. It was basically demographic data, gender, age, the absence or presence of cirrhosis, the etiology of the liver disease, the grade of the cancer based on the Barcelona staging system, and the Child-Pugh score. And we concentrated on trying to get survival data for the very few number of patients that we treated with curative intent, and we felt that it's been quite useful for us to be able to see, and be able to show people that when we do manage to diagnose HCC early, that we're able to get reasonable results. And none of this data was available to us previously. But the numbers are small, and that is one of the problems of doing these registries based on just one unit. So, like I said, based on the GECHO meetings that we've had over the last year, I think that we can all say that there is an increased awareness of hepatocellular carcinoma in many countries in sub-Saharan Africa, and there's expanding expertise in the diagnosis and management of hepatocellular carcinoma. And I think we can expect the numbers of patients diagnosed and treated with HCC to increase. I think that's something that's happening in our hospital because we're picking up more patients at an earlier stage. It's something that we've shown is happening in many countries in sub-Saharan Africa. And a registry or database may be useful in allowing collaborative research, allowing individual surgeons and centers to monitor results and changes, and to identify where things are being done well and where we can maybe improve things. So this is something that we just wanted to open for discussion, and it's something that we maybe thought that we would like to take further over the course of next year. And what we were thinking is, to start off with something very simple. Just looking at, like I said, just looking at the demographics, the etiology of the liver disease, whether there's cirrhosis or not, looking at the treatments that patients receive, peri-procedural morbidity, mortality, and ideally survival data. And perhaps down the line, we could extend databases to include patients who are being screened for HCC, and maybe also looking at patients who are treated with palliative intent, although I think at this stage it would probably make sense to concentrate on patients who are treated with curative intent. Thanks very much.
Okay, thank you very much, Mark, for that very nice summary. I think the big advantage with this, if we go down that avenue, and it's obviously completely voluntary, is that we don't only get snapshots, that you can monitor change over time as well. But I think the plan is, I don't know if there are any comments, but the plan would be just to have a draft that we can discuss at one of the early meetings next year, and with more practical things like the platform that we will use, etc. And we will also consult with, I think, with a hepatologist. There may be, we don't want to make it too extensive because it makes it difficult to be compliant. Really, just the practical information, and obviously the data will be open. The collective data would be open to people that contribute to this, for publications, etc. So I don't know if there are any comments from anybody. You're welcome to put up your hand or just unmute and speak. I didn't see any in the chat group.
Hi, Ed.
Yeah, Wendy.
I mean, it might be worthwhile including palliative patients, because we really need to be able to motivate for the need for systemic therapy. At the moment, it's really not available, and I don't think people realize that the potential benefits that one can have. So if we have data showing how many patients present requiring palliation or systemic therapy, I think that'll give us good data to motivate.
Yeah, I think we will have a discussion before we take this further, because it will be nice to have it together right from the beginning, and cover as much as we can of the important points that we need to. If no other comments, I think
I can't see any other comments. If anyone has comments, they can raise their hand or maybe unmute yourself. Doesn't look like there's anyone. No, it doesn't look like there's any other comments.
So, Chris, it's over to you then. Chris, you're muted.
Well, thank you very much. Yeah, it remains for me really to conclude and bring to a close a year of very successful GECHO sessions. And I think congratulations to Ed and Mark on really, I think, evolving what GECHO is all about. I think it's probably the best example of what we want to do in Sub-Saharan Africa, is really coordinate this enormous network that is there and try and generate data that can be put into print so that people in the world are aware of what's happening in Sub-Saharan Africa. I think that we're pleased with the progress. We're pleased with the number of participants that have enrolled every week. We're really not looking for big numbers. We're looking for the right people to occupy the right bus. And I think that's really our aim coming into the next year. We also want to try and stimulate a lot more discussion from our colleagues in Sub-Saharan Africa and get away from this kind of teacher-pupil teaching. So we're going to try and change the format a little to make it case-based discussion generated from colleagues in Sub-Saharan Africa, which we aim to target. So it remains for me to thank all the presenters, all the chairs, Cheryl and Karen for their invaluable support, to all our sponsors, and to ECHO, Sanjeev, who is always very, very supportive of all our activities in Sub-Saharan Africa. And I hope that you all have a good holiday and all good wishes for the new year. And we look forward to welcoming you back on January the 19th next year, where we will commence with our first GECHO session, which will be devoted to endoscopy. I might also add that we plan to introduce 2 new subspecialties next year, GECHO Radiology and also GECHO GI pediatric GI. So we're going to incorporate the pediatricians into all our GECHO sessions. So from me, Chris Casanides, and all my colleagues, GECHO colleagues, and the trustees of the foundation, it's good afternoon and goodbye, and thank you for attending.